reduced access to sexual reproductive health care during COVID-19 pandemic has had severe consequences for young people, especially adolescent girls and women. One such consequence is an increase in the number of unintended adolescent pregnancies, which in turn could increase pressure on girls to marry at an early age. Some reports, including that of the United Nations Population Fund, show a significant impact as a result of constrained access to SRHR services. Eastern Uganda, Busoga in particular, has had the highest reported cases of teenage pregnancies, with Luka district alone reporting more than 600 cases. West Nile and Ankole regions have also reported many cases.
Youth-friendly services cannot be accessed easily. Contraceptive methods like condoms cannot easily be got the way we used to. Young people have fear of going to the hospitals because they think that it is where COVID-19 patients reside, and they think that is where they would also get COVID from. We may not be having masks and we cannot access services that are in the hospitals.
Abalenzi bakozeeyisa ino ebiragalalagala olw'okuba nti tibali kujja ku masomero ate n'ebyokukola bitono babasibira waka.
The police has since received 4,442 cases of defilement reported between January and April 2020. This is an impact on sexual and reproductive health and rights. Crisis is affecting the delivery of sexual and reproductive health services around health facilities in the country, especially in the way they operate. Some have been closed as others convert to handle only COVID-19 related cases. In 2016, AMREF Health Africa implemented a 5-year project, Health Systems Strengthening Advocacy Project, partnering with various civil society and community-based organizations, media, stewards, among others in the country. These partnerships were critical for promoting participatory advocacy for effective policy implementation.
The project that we collaborated with AMREF is the Health Systems Advocacy Project, which was meant to strengthen systems and also improve access to sexual reproductive health services and also support with the human resources for health, building their capacity and delivering sexual reproductive health services. And in particular for HEPS-Uganda, our focus was on strengthening systems around supply chain for sexual reproductive health commodities or medicines. That was our contribution and support to this project.
The project started in early March 2018, which was firstly started by an inception meeting which we held at the Lira District Council Hall, and this partnership is intended to promote advocacy of family planning and other SRH commodities and services, but also it is a project that targets improvement of health rights in the communities, at the health facilities, but also basically staff performance, monitoring staff performance, and also staffing generally at health facilities in the Lira district. And this partnership has been done in at least 21 health facilities so far since 2018, and right now the project is coming to a closure.
The design of the project from the beginning was envisioning sustainability. And there's no activity that has been done within SRHR district as in Hope After Rape is doing. Now, most of these activities have been done together with the community leaders and the district local government officials. That's one beautiful thing about it. And you know, being an advocacy project, we had to approach it that way to create a win-win ground.
And the key interesting was when we were starting this project, the availability of key commodities that save, for example, mothers from dying, overbleeding, and also medicines for managing preeclampsia cases, which are the leading cause of maternal death among mothers that are delivering and pregnant mothers.
Specifically, this program on our side looked at strengthening health systems so that they can deliver sexual reproductive health and rights services, especially looking at the issue of having adequate, well-skilled human resources, having strong leadership for sexual reproductive health and rights, having adequate commodities in the health services, focusing on ensuring that the services are of sufficient and quality that meets the demand of the community.
The project was focusing on 3 issues. That was to reduce or minimize or eliminate health worker migration in the district. Number 2 was to ensure that family planning commodities are available in all health facilities and all the method mix are available, so that whenever a woman has already taken on a method, should at least always get that method to avoid taking on a second one or even failing to continue with the method when it is not available in the facility. Then another issue was to ensure that young people, adolescents, access reproductive health services and information so that they don't mess up with their lives, so that they can also know what to do in case they have the body changes, in case they need information where to access it. Before we implemented the project, we had to first bring on board all those stakeholders. We mapped out like-minded civil society organizations which were mobilized from the district advocacy working group. This was intended to have a collective voice so that when we are advocating, our voices can be heard, and also when we combine the efforts like all civil society working in health in the district, then it means nobody will be witch-hunted.
Apart from that, there have been other activities because we've been more of an advocacy organization, so supporting the district basically to produce position papers where gaps that have been identified need to be amplified out. So we have already cited a number of issues that exist, like adolescent youth-friendly services that were originally not fully present in the health facilities.
Majorly, the problem has been the variety, especially for sexual reproductive health services, even when it is the same for other services. But you know, when it comes to sexual reproductive health services, particular individuals respond, especially the women, on issues of family planning, respond to particular methods differently, others with adverse effects. So there's need for having a variety.
And so initially, I didn't have the capacity, I did not know even that reporting on an instance where girls are unable to access sanitary pads would make a story and would help them in the long run. But that training helped me so much in that way.
Abashimiye kuba bara actinga hanshonga z'abantu katugiye no buhereza bw'amagara bachurirwa cyagamba ha radio lejo echo njija okubahaririza njija kubashyikiriza okugira ngo barawukeho okutuma nkora habo kubensi yona nebe bahurire nimba nakora ki nimba nabata ahari muranga habwo kugira ngo enshonga nabasa kubanizanjura aha radio.
SRHR Health Center for had garbage everywhere, but when it went there and then it brought up that issue, we eventually swung into action, and now SRHR Health Center 4 has a good rubbish pit where everything is dumped, no longer garbage everywhere. Pingre is a good example, had a very poor maternity, and it has been there for long, and we have been seeing it. But when it came in, its impact, when it visited that facility, and it came and brought it to the district. The district had to swing into action and the sub-county had to renovate the place.
Support supervision. We would move with them to health facility. They support our teams. They are able to reach in health facilities, identify issues that affect both the health workers and the patients, and they come up with the community questions which they will be addressed by other different stakeholders.
The organization also supported us a lot by doing some sort of survey, I would call it like that, but we were moving to all the facilities to assess the status of family planning commodities in these facilities. And after we have done it all, it gave us highlights to do a great job on the issue of redistribution of family planning commodities where it was lacking and where there were somehow many. So we were able to pick from a facility that are having and take it to the facility that were lacking.
Kawale district did not have any budget for family planning. Worked with them, worked with the district budgeting desk, and finally were able to include in 5 million per year for advocacy for family planning uptake. And we are happy that this has been maintained, and even now, even this financial year, we are implementing that, which is very good for our communities. We had facilities in Kawale district that were not accessing medicines. We are not on the essential list of national medical stores. We would contact them, but they had taken long without listening to us. But when the advocacy took this, it was up to the national level, and we are glad that these facilities recently started receiving medicines. For the last 6 years, they are not on the list.
However, the impact of the measures to manage the spread of COVID-19 disrupted the supply chains and restrictions to freedom of movement.
Young people, even other patients, feared to come to the facility because they thought maybe all the facilities have COVID-19. They also had problem of transport to reach the facilities because at that time of the lockdown, even transport was cut off. We could only respond to emergencies.
The onset, especially during the lockdown, the demand of course had to go very low. And you know, the consequences of that was, and yet some are yet to be seen, high numbers of pregnancies, infections with STIs and STDs you get, and then of course limited access to sexual reproductive services. It put the lives of these, especially the young girls, at stake.
Some health workers do not have skills for providing these family planning methods, especially long-term methods. But we were able to work with the project, advocate for this, and the district would take it up, looked for the other partners who would train. And I'm happy that most of our health workers were trained to provide the family planning. Secondly, the logistics availability. Logistic availability was, we had inadequate family planning methods, especially at health center 3s. Long-term methods were not there. They were not part of the kit for the health center 3s. Worked together, advocated for this, and the government had to include it on the essential list for the health center 3s. Now they are able to provide long-term methods. Thirdly was information, mobilizing and sensitizing community to uptake these initiatives. Because we budgeted for that, we had to have radio talk shows, engage even other partners who would support us in creating awareness, and we have seen the rise in the uptake of these family planning methods.
I can only demand for a service when I know about the product, I know the use of the product, and I also know the dire consequences if I don't use this product.
We realized, because when we used to go and monitor, when we're doing follow-ups in the health centers, most of the family planning methods were not fitting these people. People were fearing to use family planning. When you go, most of the drugs were getting expired in the hospital. But when we went deep to discuss to the community, to talk to these women as to why they were not taking this as a method of what controlling what, but we looked at it also helped us to know that family planning was not all about stopping what production.
Civil society organizations called on government to recognize that these services are essential at this time.
If the CSOs, who are actually close partners of government, go shutting down, then it means we are shutting down some services that government has actually mandated us to offer on their behalf. These young people love to confide into their peers. We have to create a group of peer champions or peers who are impacted with knowledge, or who are full of knowledge to do with sexual reproductive health. And it is these peers who are supposed to be our foot soldiers. In most cases, if you went to these youth, even if you went at the right time, in the right setting, but you are having a bit of gap in terms of age, there's that generational gap, they will listen, but sometimes they don't take you serious, and they may not express themselves openly as they would with a person of their age group.
We want this good practice to continue because it was just a high opener. Okay, we have realized that even without this project, there's small things that we can do. We can sustain this committee. How? We have talked to the health management unit of the of our health facilities that we have. First of all, they need to integrate one young person into the health management committee. But also that young person, we have trained that person to influence the decision in the health management committee, such that whenever there are issues there, they can also give allocation to the youth, okay, in the facilities. They can also maintain the youth-friendly corners. They can also maintain the pool table that we have opened there.
The project has been only covering about 2 to 3 sub-counties in SRHR district, but wanted at least the project to cover our audience so that it will benefit a number of people.
Youth champions have been trained to help us talk to these youth about the sexual reproductive health and where they can get the services. Okay? And then we have the VHTs who are there, and those ones live in the community. So we needed to continue sensitizing them on both issues of COVID-19 together with the sexual reproductive health, so that the services all flow at the same time, and they should get the right services at the right time.
Even without a pandemic, women in Uganda face barriers to accessing sexual and reproductive health services. COVID-19 has placed an extra strain on this issue, while many services shut down to maintain physical distancing and avoid further infections. Women still very much need SRHR products and services. Life goes on and sexual interactions continue, even amid the challenges COVID-19 presents.